So good morning, everybody.
Good morning.
Good morning.
Good morning.
We thank everyone for giving us a few more minutes to get things adjusted and
technology. So.
Yeah, you know how technology is. We're just glad to have you here. And if you see, these messages are in the presentation on your screen, that right now the mics are muted. Right there, that's me with a totally different hairstyle. And I'm one of
this is me. This is Cheryl. And this is our special guest today, Dr. Gabrielle Bercy. We can't wait for the presentation. I'm going to leave this slide on here for just a minute so people can get an idea of the setup and where we're going today. This is the agenda. We're going to do welcome and introductions, and then we're going to turn the floor over to Dr. Bercy, who's going to give a presentation. And then following her presentation, a Q&A session. And then we really hope that you stay around and fill out a very quick on-screen evaluation. Helps keep us in line. So right now, if you would, introduce yourself. You can do it by unmuting your phone and just saying your first name and then tell us one thing that you are secretly pleased that you don't have to do now that we're physically distancing ourselves, and one thing that you really miss doing.
Right.
And you can go ahead and unmute yourself, or you can type it in the chat. So again, and if you have your mic open, but you're not sharing anything at this time, you can go ahead and mute yourself if you like. So the question again is either in the chat or audio. What is the one thing you're secretly pleased that you don't have to do now, that you are that now that you are physical distancing, and the one thing you really miss doing? Anyone?
Sorry. Hi, this is Adrienne Bradshaw from Ohio.
Hi, Adrienne.
Hi, Adrienne.
Hello. I am secretly pleased that I don't have to sit in in-person meetings. We're still doing Zoom all day.
Oh, wow.
It is a little bit less pressure on the Zoom meetings because you can turn your camera off and get up and do other things that you want to do and not just be stuck sitting in meetings all day.
Exactly.
So I'm secretly happy about that. I've gotten used to it, I guess. The thing that I really miss is all of my music. I miss having choir rehearsal on Saturdays. I miss having my gospel ensemble that we go out on Sundays and sing at churches. So I'm really missing that part.
That's interesting. Those are the things that connect us on a weekly basis and part of our routine. Thank you, Adrienne.
Anybody else? Just your first name and where you're from?
Hi, my name is Jessica. Oh, sorry. My name is Jessica Arcee, and I am in Springfield, Virginia. Same thing as the first caller said. I am secretly happy that I do not have to go to the office. I am able to work from home. So it's been 2 months of working from home. One thing I do miss is going to like music events and like movies and just being like outdoors. I'm like a people person, so I like to be out and about. But now I miss it, but don't miss it too much because of the virus.
Yes. Thank you, Jessica. I hear you. I miss music as well and going on outings as well. Thank you. Anyone else? Just state your first name, where you're from, the state or country.
Hello, my name is Joy. I'm from England, in London. Hello, and I'm currently on maternity leave, but it's nice to see when you go to the shops how people are more thoughtful now and not so greedy, so that's nice. But I miss not going out to visit like friends and families and social gatherings and things like that. I
Yeah.
would say.
Yeah.
Yes, that we hear you, Joy. Thank you
Yeah.
so much and from joining from England. It's nice to have you with
That's
us.
great. Yeah.
I think someone just opened their line as well. Who else?
Hi everyone, my name's Amaka. I'm
Hi,
calling
Hi,
from
Amaka.
England, London as well.
Hi.
Oh, great.
Yes.
Hi ladies.
Hi.
So basically what's been good about the coronavirus for me is the 2-hour commute I do to work and back. So that's 1 hour each way. So it's been good that I don't have to do that anymore.
I can relate. I can relate.
And the bad for me is really just being able to hug loved ones, and yeah, that's been the bad for me.
Yeah, and hugging is part of our self-care and a need that we have. And sometimes we don't realize it until we don't have it. So yeah, thank you for that, Amaka. And thank you for joining.
Anyone else?
Hey, this is Nicolita Johnson
Hi,
from
Nicolita.
Hey,
Hey, Nicolita.
how are you both?
Good.
I think I know both of you, but
I think so.
all right. Yep, this is Nicolita Johnson from Fairfax, Virginia. Let's see, what is the one thing that I'm secretly pleased that I don't have to do now? And that is to look at getting things done in just one way. I think with the social distancing and having to look at options and alternatives, I'm pleased about that, and recognizing and knowing that I can do music another way other than live. I can use Zoom, I can use Facebook Live. So I'm secretly pleased that I don't have to look at doing things the same way. What I miss is we just had a new grandbaby on March 16th, and I haven't had the opportunity to really kind of hold him. And he's just 10 minutes down the road, but we don't get to interact the way we did with the first grandbaby. So I miss that totally, as well as just having family members over for dinner and being able to relax and not think about, all the things that we now have to think about.
Wow.
So, yeah.
That's amazing. And you said grandbaby number 2, so I'll talk to you about that later. But, congratulations and thank you so much. And I think we're all nodding in agreement. We understand that. Anyone else? I think I heard some other lines open.
Hi, my name is Priya. I'm calling from Canada, from Toronto.
Hi.
Nice to see you and meet you.
Nice to meet you. I would say I'm happy I don't have to wear real clothes right now, because when you're in pain and it just you just don't want to wear jeans. So that is great. And then I'm missing going to restaurants and sitting down, and I'm grateful for pickup and curbside, but just like sitting down for an hour and getting away from eating in front of the TV. I miss that.
Yes. We totally understand. And I think what's beautiful right now is just hearing people from all over the world, really, and seeing how quickly we connect on some of the basic
on the same topics.
I think I heard
Doris.
No, Priya, what did you say? No.
And I mentioned I'm actually this week I was supposed to stop in Atlanta, but obviously I can't get there because of the border closed. So I never thought this would happen. Yeah.
Oh my, yes. Well, welcome. We're all one community. And I think I heard Doris. Thank you.
Yes, you did. Can you hear me?
Yes, we can hear you and see you.
Okay. Good morning.
Good morning.
Calling from Cleveland. I miss nothing much. I mean, it sounds weird, but I like the nostalgic feeling that I have from being a kid, where life just was always slow in the Caribbean. And even though we did stuff, we did it at our own pace. So now I feel like I'm there again, where, okay, you're doing what you want to do, but at your own pace. There's no deadline to meet, no rush, besides going to work in the basement. But I enjoy that. I do miss having more company to come over, and the fact that I do have a restriction where not to go. But all in all, I am happy I'm able to work on my planting and do little stuff around the house. Unfortunately, we had a flood yesterday,
Oh, I'm sorry.
from all the rain. So I have a hard time hearing because the fans are going. But
I'm sorry to hear that.
I just like the slow pace right now of doing everything, including working from home. So
Very nice.
that's it.
Wow, we need to rise up and make sure we share it for those of you that are working from home, you know, to share these comments really with your employers, because it would be nice if this is the way that we could function moving forward more often. So, and was there someone else who?
Joan Clayton Davis.
Hi, Joan.
Hi, Joan.
Joan.
What were the two questions?
Yeah, well, the first is to introduce yourself and the state or country that you're from, and then to say, what one thing are you secretly pleased that you don't have to do now that you are physical distancing, and the one thing that you really miss doing?
I'm Joan Clayton Davis from Nashville, Tennessee, and what I like most about COVID-19 experience is I don't have to wear anything that's binding, like a bra.
Yeah.
Exactly.
Unless I'm going out.
Yes.
And what I miss, I do like the calmness of it. And living in an urban area, I just like the peace of it. And what I miss most is planting gardens.
Yes, I understand that. Yes. Thank you, Joan, for that contribution. I think we said we will take one more.
Yeah, because we have to talk about what we're here to talk about. We want to give our presenter plenty of time. So
Good morning, everyone. I'm Chris.
Hi, Chris.
Hi, Chris.
Hi, I'm from the DC area here in Northern Virginia, but originally from New York.
Yes.
Glad to be on the platform this morning. And I don't miss, similarly to what other people are saying, I don't miss the grind of the Washington, DC metro area, of just that constant intensity from traffic to rushing to just all the crazy things that go on here. So I am enjoying the peacefulness of that, but I'm a social person. So I am not jazzed about doing all this stuff online because I miss the human interaction. I miss my family in New York, whom I haven't been able to visit, especially since they're very hard hit up there. Haven't seen them in a pretty long time now. And I miss just being with my friends and family. And even when I teach adult English, as a second language. So I miss interacting with the students in person because it's not the same, for me, it's not the same connection as best as we try on Zoom as it would be in the classroom.
Yes.
So pros and cons.
Pros and cons. And that's what I'm hearing from everyone. And please to continue chatting, add some comments in the chat, but and we are going to move into our program. Thank you all. It was so good to connect with you in this way. And we feel that it's very important that we do, especially in these times that we're all experiencing together. Cheryl?
Thank you, everybody. So this morning, I want to officially welcome everybody and thank you for joining the Institute for the Advancement of Women's Health in our Saturday morning Women's Lounge or Ladies Lounge, where small groups of women can gather to learn about women's health and get up close and personal and ask difficult questions that have been nagging you and you of a health professional that we have as special guests. My name is Cheryl Thompson, and I'm joined by Janine Payne, who we've already met. And we are the co-executive directors of the Institute. But before we begin, just to go over some lounge etiquette, some things to keep things moving smoothly, just want to share with you so that we can keep things moving and everybody can stay relaxed. So if you will, since we've all been talking, put your systems back on mute just so that when the presentation happens, there won't be any disturbances. are a community now. We are a little tight community. I think there's going to be about 30 of us here today. So we want interaction. So use the chat box. And when it's appropriate, go ahead and unmute yourself and speak right up. And then finally, if you're comfortable, and I see that a lot of us are comfortable, please use the camera, but you don't have to, because we're just happy that you're here.
We are indeed. And this is just a little bit about Cheryl and I, and we're gonna move through this so that we can get to the content that all of you are gathered here to share and to learn. Cheryl and I are from the Midwest, and we started, and now we live right outside of the Washington, D.C. area. And we started IAWH, the Institute for the Advancement of Women's Health. It's a nonprofit, and the goal is to establish a sense of community among all women, and we're working towards that. And you can see that, I can hear that also in the responses that we received from you all. We collaborate with local and national experts. So thankful to have Dr. Bercy on the line, and advisors from community-based organizations, and public health departments, academia as well, but all to bring a very holistic perspective, if you will, because we are dynamic. Women are dynamic in so many different ways. And so we want to be able to bring really the weight of what we have available to us to these discussions. So Cheryl, I think you have.
Yeah, I just want to tell you a little, just quickly, so we can keep moving.
Yep.
What the Institute does and what we're about learning. So we want to be able to inform and educate the public about women's health and wellness from an evidence-based approach. And we are into the improvement of the quality of life of women across the life course. So at every age, we're looking at every aspect of public health and mental and physical health as well. And then finally, we are about, Janine and I are both public health professionals and come from research backgrounds. And so we really are anxious about and excited about conducting community-based and community-level public health research.
All right, so let's get into a little data, and then we're going to turn it to Dr. Gabrielle Bercy. Some data on endometriosis and uterine fibroids in the United States. So according to the U.S. Health and Human Services Office on Women's Health, an estimated 11% of reproductive age women, and that's between the ages of 15 and 44 on average, are living with endometriosis. It is especially common among women in their 30s and 40s. About 26 million women suffer from uterine fibroids. I was one of them. About 20% to 80% of women develop fibroids by the time they reach age 50. Fibroids are common in women in their 40s and 50s, right where I was. So as Cheryl mentioned, this is why we have an expert in the house. We're joined by our special guest, Dr. Gabrielle Bercy, to bring us the facts. She will discuss fibroids, and we're going, and she'll share more about how we're going to move forward in other sessions as well around endometriosis. Dr. Gabrielle Bercy is a board certified obstetrician and gynecologist, OBGYN, with 22 years of both clinical and administrative experiences. Her most recent position was at the Blue Cross and Blue Shield of Vermont, where she was the senior medical director. She has served as a women's health OBGYN expert on various panels. She is a fellow of the American College of OBGYN. She has done medical volunteer work in Haiti and Senegal, and she is married and a mother of 3 boys. We applaud her for that in and of itself. And Dr. Bercy, we like to turn this over to you at this time. So, and we thank you for having us. We can share applause in the chat and just welcome Dr. Bercy as she brings her presentation to us.
Great, thank you so much for the invitation. I just want to find out, can you hear me very well?
Yes, we can hear you and we can see your presentation as well.
Okay, excellent, thank you. Just to say good morning, and it's really a pleasure and a privilege for me to be invited to give just brief presentation Initially, I was going to focus on both fibroids and endometriosis. However, my computer conked out. So that's why we're going to focus on fibroid today. And then I will work with Janine and Cheryl to bring you a similar talk on endometriosis. However, if you have endometriosis questions, I'll be more than happy to answer all the questions you have. So I give myself, 2 hours. So, I'm here. So I'm with a brief outline of my talk. I will first focus on the epidemiology statistics, and thank you for giving that amazing information. So that will shorten the information I have to give. And I will also focus on the clinical features, the types and stages of fibroids, as well as present symptoms, and talk about diagnosis, treatment, and give a brief conclusion. So we can start. And if you have any questions, you don't understand anything, you can raise your hand in the chat box, and Janine can monitor that for me while I'll talk. And then she can unmute herself and say, somebody has a burning question, can you answer that? Or if you need any clarification, because I don't want any confusion in that way, then, because if somebody has one question, probably several of you may have the same question. And I just wanted to be clear, this is a learning session. So fibroids, as it's been referred, the proper terminology is called myoma or uterine leiomyoma from Greek. And it's the most common pelvic tumor in women. Tumor doesn't necessarily mean it's cancer, it just means tumor is a mass. And most of the time tumors are benign, meaning that they're not cancerous, and they rarely become cancerous. And fibroids are basically non-cancerous monoclonal, meaning like one cell line tumors that arises from the smooth muscle cells of the uterus and the fibroblasts of the myometrium. What does that mean? That means that your uterus has muscle cells. Most people don't know that. And your uterus has also fibroblasts. These are the cells that becomes muscle cells in the myometrium. I will show you a picture of what the uterus looks like later, and you'll have a clearer picture in your mind. And also too, fibroids arises in the women of reproductive age. And fibroids can have reproductive effects such as infertility and adverse pregnancy outcome. And also too, can also impact your life in terms of your ability to work, for example, based on your symptoms. Do you have any questions? So this is the statistics. You have to unmute yourself, Janine, if you have a question.
Yeah, I know, I forgot. No, I was going to say, just to repeat, if you have questions, you can add them to the chat box, and then I will be sure to share them with Dr. Bercy. Thank you.
So thank you so much for giving those statistics, because it's the same, very similar that I have. Overall, the incidence of fibroids is both affected by age and race. So Black women, most studies have shown that they have a prevalence as high as 40% when you compare to the 40% when you compare to white women, 20% overall population. You can add the overall age group from 20 to 55 in terms of menarche to postmenopause. However, when you break it down by age, you find that as women get older, both Black and white and Latina women, the incidence of fibroids tend to increase as one ages, which is a natural process. So you'll find that if you're under 25, it's extremely low to have fibroids. However, between the highest age ranges is women in their 40s. Typically, these women have had children already. So if you, for example, take 1,000 women, right? If you're the age between 25 to 29, 3 of you will have fibroids. If you're 30 to 40 to 34, 7 of you, versus if you're 35 to 39, it's 10. But when you're at 40 to 44, 16 of you will. Now, this is the anatomy of the female pelvis. Just, in that way, when I continue my talk, you have a picture of your mind. So in terms of a drawing, what sits in front of this is your uterus right here. Your uterus is the part whereby, right here, that's where, inside here, that's where you carry the baby, okay? And this right here is called the endometrium. And that's the lining that sheds when you have your period. Okay, every month that sheds, you get a period. Now, this is where we have the fibroblasts that I mentioned before when I talk about the pathophysiology. Now, this is the smooth muscle of the uterus, right? Okay, and this is the part right here that basically contracts the uterus, okay, whereby when you have your period, it stimulates, and then this particular area sheds and then give you a period. And this is the outer part of your uterus. And this is your fallopian tube right here. That's what's grabbed the egg and the sperm, causing you to have it travels, and this is your fallopian tube. And the fertilized egg end up in right here in this area right here, causing to have a baby. In the back of your uterus, you have your colon, okay, right here, your big colon. And this is your rectum right here. And that is your anal canal. This is your vagina right here. And this is your urethra where you pee, right? So go through your anatomy, your urethra where you pee, the vagina that sheds, that's where the blood when you have your period, and your colon right here, that's where you, right? So it's very important that, you know, this anatomy remains intact, because anything, as you can see, that affects here can have repercussion for here, right?
Right.
Okay. So now again, this is a pictorial review of what, you know, this is again your normal uterus. This is your cervix. This is where we do the pap smear. Okay. This is the uterus, the uterine canal. Again, your ovaries and your fallopian tube. Now, this is the innermost layer of the uterus. This is where the muscle is. And out here, this is the outer layer. Okay. Now, when we have fibroids, we have different types of fibroids, right? We have fibroids that can project into the uterine cavity where you carry the baby, right? You can have fibroids that's in the muscle of the uterus, like here or here or here. You can have fibroids that's outside the uterus, right here, right? It sticks out. And you also have fibroids that can totally stick out. It's called pedunculated, and it has a little stalk to it, okay? Those are the type of fibroids that women can have. And depending which type of fibroids you have will give you different problems, okay? So some fibroids will give you bleeding. Some fibroids will give you pain. Some fibroids will give you incontinence. And some fibroids will cause you difficulties getting pregnant. So we will, again, just think about this picture, okay? Any questions?
If you have any questions, please add them to the chat, and we will ask Dr. Bercy to respond to them.
Okay. Any clarification or any confusion? No? Okay. So those are the different type of fibroids. And this is another representation. In addition, women can have many types. So you could have one of this, one of here, and one of here, and one of here, okay? So when you have multiple fibroids, things can be a little bit more complicated in terms of what kind of treatment we'll offer you. Because if you have this, it's one therapy that's very specific. But if you have multiple, if you have one that's here, and one that's there, then you have to think of what's the best therapy is rather than have multiple therapies. Okay? Now, what are the risk factors for fibroids? Can you reduce your risk of having fibroids? Well, age is a natural process, and we want to live as long as we possibly can. So we cannot modify that. We have no control over that. Early menarche, meaning that the earlier you get your menstrual period, is associated with having fibroids. And this is because when you start menstruating, you start producing a lot more estrogen. And we know that estrogen are responsive to estrogen and progesterone. So that's why when you get your period early, if you get a period early, then you're at more risk for fibroids. How about getting pregnant? Studies have shown that women who are able to achieve one or more pregnancies beyond 20 weeks have a decreased chance of getting fibroids. So again, when you are pregnant, you're not bleeding, you're not having a period. So therefore, that's maybe the reason. How about using, when women use low dose oral contraceptive? Low dose contraceptive does not appear to cause fibroids to grow, okay? How about, now that women are delaying having children, so there's the more women are having IVF, how about if you undergo IVF? So there haven't been any credible cases whereby ovulation induction IVF treatment increases your risk for fibroids. How about environmental factors? There's certain chemicals that seems to have an increased risk of fibroids, but it's a link. It's very, very, very weak, and it's probably due. They think that it may due to hormonal disruption.
Excuse me, Dr. Bercy. Someone asked a question. They said they have a question about an ablation that has totally stopped their cycle. Should they worry about their lining?
Okay, we will answer that at the end of presentation.
Thank you.
That's okay. Okay,
Of course.
We'll talk about ablation as well as
Thank
part
you.
of the surgical therapy.
Thank you.
Very good. Thank you. So how about if you are overweight or have obesity? Obesity, yes, there is a link between fibroids and increased body mass. That is because we know that when you are overweight or have overweight, estrogen tend to be stored in their fat cells. So therefore, women who are overweight, they tend to have more fibroids, and also too, women with obesity, they tend to have delayed menopause because they have increased estrogen in their body, especially that. How about diet, alcohol, and smoking? Studies have shown that if you, it's a link. Again, it's not a definitive thing that if you consume a lot of beef, a lot of red meat, there's an increased risk of fibroids. However, if you eat a lot of vegetables and fruit, that decreases your risk. Again, is it because those patients who are eating beef and red meat, they tend to be overweight versus those who eat vegetables and fruit, they're leaner, so therefore they have less endogenous, meaning they have less estrogen in their fat cells. So, but however, it's important to eat as much green leafy vegetables and fruit as possible. How about dairy products? Certain dairy products like soy, for example, that may have estrogen in it, but the studies are very, very conflicting. And in terms of glycemic index, again, that goes to being overweight. Overweight, if you eat food that's more higher glycemic index, meaning that food that contains higher amounts of carbs and sugar, that'll put you into the obesity, overweight category. And again, we know that these women tend to have more estrogen around. Okay. And also too, there are various vitamins. Some vitamins help and some vitamins does not help. How about alcohol consumption? Again, we went to that beer. Patients who drink beer, they tend to have more of a belly. Again, it's not necessarily the beer per se, but rather their overall health. Smoking. So early study did show that there was a possibly decrease risk of fibroid. And again, we know that people who smoke tend to be less overweight because of the smoking effect on their weight. So therefore they have less estrogen, again, maybe a decreased risk. And look at genetics. Yes, studies have shown that women who have family members, especially first degree relative, who have fibroids, like their sister, their mom, their aunts, tend to have fibroids. And this is particularly true in Black women. And there are multiple studies that's being done at various centers to try to find out specifically what the genetic mutation are in terms of fibroid as it relates to Black women and Latina women and women in general in some institutions as well. How about other factors like high blood pressure? High blood pressure is associated with increased risk of fibroids. Again, women that have high blood pressure tend to be overweight as well, and they also tend to be diabetic. And uterine infection there were some earlier studies, but none that those studies have been not substantiated when they were repeated. Any questions as it relates to risk factors, genetics, or incidence, or anything like that?
Dr. Bercy, I think you've covered some of this, but one of them was why do African American women disproportionately suffer from this diagnosis? And you've talked about obesity and other chronic diseases having that effect as well.
And also genetics as well.
Genetics, yes.
Yeah, genetics definitely play a role in Black women. Okay. So when women have fibroids, what do they present with? So a lot of times they'll present what we call bulk symptoms, meaning not only do they have pain, pressure, they also may have some pressure from the fibroids to the bladder that can give them urinary tract infection or incontinence. They may also have bowel obstruction whereby the fibroid is compressing on the rectum, giving them constipation. And sometimes too, when it's that large, it can compress on the vena cava, which is the big blood vessel that carries blood away from the heart, that carries blood. So therefore, the compression can cause them to have some venous thromboembolism, blood clots, for example. So they can present with a lot of with different symptoms depending on and where the fibroid or fibroids are located. So I'm going to back to my the picture of anatomy that I showed you before. Okay, so just imagine, right? So this is a picture of the uterus. If you have a huge fibroid here, for example, right, it's going to compress on your rectum. So if it compresses here, compress the rectum, you're going to have problem with constipation, right? So it makes sense because the all the fecal material written up top, and you won't be able to poop, or if you poop, it'll be you're gonna have some difficulties, some pain or some pressure sensation. Just like here, if you have a big fibroid compressing here on your bladder, you may be the one of the person gotta go as soon as you have to go, right? You may be able to leak urine even before you make it to the bathroom. You know, that makes sense. Just like if you have the fibroid compressing here, when it compresses here, for example, not only does it make you incontinent, imagine having a ball, right? Imagine your bladder is a ball and you have like some weight on it. Eventually it'll decrease the elasticity, the tone of your bladder. As a result, your bladder become weak and now you're not able to hold your urine. So therefore, that's why sometimes women that have large fibroids have incontinence. And also too, here, if they have any problems, they may have constipation, problems, pooping. Now, also, if you have fibroids here on the cavity of your uterus, right? Like right here, that's the part that's that's the part that sheds when you have your period, right? So when you have that, it may causes blood to hold right here, the blood not to go down as it should right here because it's being compressed. When that is being compressed, the blood stays in there, you get a severe cramping, or like contractions like you're having a baby. And sometimes some women, when they have their period, they say, oh my gosh, it feels like I'm having another baby. That's because the blood stays in there and it doesn't come out, right? So that's a problem. Now, if you have a fibroid here and here, that's the muscle of your uterus, you're gonna get a lot of cramping as well, but you're gonna bleed sometimes like crazy because the uterus is contracting, excluding blood out. And these are the women that tells me that, oh, I'm changing my pad every 2 hours. I am bleeding like for 10 days. I'm bleeding for 7 days. So therefore, depending on where it is, it can cause you pain. Now, if you have fibroids that's up here, for example, it's not in the muscle, it's not inside your uterus, it's not compressing your bladder or your bowel. If you have it right here, the problem you'll have is that now you have gastrointestinal problem, right? Because it's big, you may feel a sensation of fullness, whereby it's compressing now, not on your large intestine, or your small intestine. So therefore, you may get the sensation of fullness, whereby you're not eating as much, or when you eat something, all of a sudden your small intestine is being compressed. So therefore, you may have vomiting. You may have you may not be able to eat as much, or you may start experiencing abdominal pain because your intestine is being compressed because it's full after you eat. So depending on your symptoms, you could have different presentation in terms of the fibroids, how you present. Any questions?
Yes, there was one question that came up in the chat. You mentioned earlier about vitamins being helpful. What vitamins in particular were you referring to?
Well, they looked at all the studies that no one vitamin is say that they'll prevent fibroids, no tea, no anything like that. But in general, it's good idea to make sure that your vitamin levels are adequate. And the main vitamin that women found to be lack of or deficient, and also that can have an impact in not only on fibroids and other problems such as autoimmune problems, patients with breast immunity, is vitamin D. And in view of the COVID-19 pandemic, there's a specific studies that women or patients who are vitamin D deficient, they have a higher much disease severity as compared to other patients. So, and also the reason and the logic to that is that vitamin D, deficiency in vitamin D is linked to having certain autoimmune disorders, for example, like lupus, MS. So it's a good idea for all women to get their vitamin D level checked by their PCP. What I recommend is that, for women to take a vitamin D every day. I even make sure that's part of my kids' regimen. I put on my dining table, everybody in my house, it's Gabby's rule to take a vitamin D tablet. My children, everybody, because it's very important to do that.
Okay, a clarifying question, is it D or D3?
Vitamin D3.
Okay.
Thank you.
And they have a lot of sale. And if you take, I definitely would recommend just start taking it now. It's not going to hurt you. And when you are able to see your primary care doctor or your nurse practitioner, then definitely have your level checked.
There's another question, and this person says that I was sadly diagnosed with MS earlier this month. It was brought to their attention that MS can cause pulmonary fibrosis. Is this correct?
Okay, this is a specific question related to MS. I'll be more than happy to answer it after my presentation.
Thank you. I just wanted to make sure I brought that forward. Thank you.
No problem.
Thank you.
Now you're welcome. You're welcome. So let's go on now to talk about diagnosis. In the interest of time, I'm going to shorten my talk. And I just want everybody to ask everybody, do they understand everything so far in terms of, Okay, so let's talk about diagnosis and evaluation. The first step in diagnosing patients with fibroid is to do a physical exam. Sometimes the fibroids are so big that you have and if the patient is not overweight, then you have them lie on the table. You can readily see their fibroids, and it's right there. So that tells me that they've been suffering for a long time, and it's now that they want to, get it taken care of. Okay, so that's number one. So you do an exam, or you do a bimanual exam. Right now, currently, we don't have to do a bimanual exam. It's not necessary. It's not because we know that ultrasound is more accurate. So most importantly, I would tell my patients, okay, I can do an exam if you want. If not, we can get an ultrasound. Most of the time, they want me to do an ultrasound just to figure out how big it is. So when it's up to your belly button, that means it's 20-week size, meaning that patient, their uterus is a 20-week pregnancy. And sometimes too, it can get bigger as a 40-week pregnancy, as if they're having a baby, they're ready to give birth. That's how big it can get. In terms of lab testing, the only time we'll do lab testing is, for example, if they complain that their period is very heavy and they're feeling very tired. So that tells me that she's been anemic, okay? She's been anemic and been suffering as well, if she's tired and having heavy menses. Some women will say, oh my gosh, I change my pad every 2 hours. I have clots and I bleed for like 10 to 14 days. And my things that, where have you been? Why have you come and see me or see another OBGYN? And she said, well, I've been working. I'm like, okay, well, I'm glad you're here right now. And we also check for pregnancy, because we know that the common cause of enlarged uterus, uterus to be big, is because you're pregnant. And sometimes women don't know that they're pregnant because they're busy. You know, they take their birth control pill, they practice, you know, mindful ovulation, and sometimes they still get pregnant. And you check a pregnancy test. And also too, when they tell me they're tired, I always check their thyroid function to make sure that they don't have any thyroid problem. As we know that thyroid problem is very common, and it's a problem that's not regularly diagnosed, because women think they're tired because they're doing like 5 zillion things, you know, being a 24-hour, you know, being a mom, and being the CEO of your home, the operating officer, and all those jobs that we do. So therefore we're tired, and in fact we do have a medical disorder that that can be well treatable, whereby you don't have to be tired. And I tell them you don't have to bleed like stink anymore. And then, you know, in that way you can get your energy up, and you can feel, and you can have some, you can have both energy by treating your thyroid problem, and also to treating your anemia. So those are the lab tests that we will do. Now, ultrasound is is our first line of modality that we use to diagnose fibroids. And we can do a normal ultrasound, meaning that whereby we do the ultrasound trends abdominally, put it on your tummy first. And then after that, if we cannot get the answer, then we'll do what we call a vaginal ultrasound, whereby we insert the probe, the probe inside the vagina. In that way, we can see exactly how many fibroids there are, where they are located. And also too, we like to know that the uterus, the ovaries and tubes are okay. Then we'll do the ultrasound. If the ultrasound cannot give us a definitive answer, when we do both the normal and the saline, or let me talk about the saline. The saline ultrasound is when we do the ultrasound, we insert the small catheter inside the uterus. Let me go back to my my slides, my picture for you. So when we do the saline ultrasound, what we do is that we insert a small catheter here, and then we inject some fluid, some saline, some water, okay? And then we get a clear picture of the uterus, all right? And that will tell us if we have fibroids inside the cavity here. It won't tell us about fibroids outside, but it'll tell us whether it's a submucosal fibroid, and it'll tell us too whether the fibroid is pedunculated, has a stalk like here. In that way, then that'll help us when we do surgery, okay? And for women who have infertility issues, for example, and they have fibroids, what we'll do too is that they will inject some fluid too, because the fluid you inject here will flow to the tube. That can tell you whether the tubes are open or not. But however, the best test to do for that is a dye test called a histosalpingogram that tells you about the tubes as well. So a lot of times women will have both procedures done to assess the tubes. But the main time we do the saline ultrasound is to look at the inside the uterus to see if you have a fibroid or a polyp. The MRI, we'll do the MRI when the ultrasound cannot tell us exactly you know, how many are there, because sometimes the uterus is so big that the ultrasound is inadequate to give us the answer. So that's when we will do an MRI, because the MRI will tell us how many fibroids there are, where they're located. Will give us a picture just very similar to the anatomy that I showed you, that I showed you earlier. So the ultrasound is the preferred modality when the uterus is big and in preparation for some kind of intervention, whether it's surgical or medical, and also to depending on the status, the medical status of the patient as well. Now, CT has no role because CT is not that it's not good at all for helping us diagnose fibroids. We do hysteroscopy when, again, we want to look at inside the uterus. And sometimes we'll do the hysteroscopy in the office or in the hospital. Now, when we do office hysteroscopy, when, again, the patient have different symptoms, we want to take a quick peek. In that way, that'll guide us as to what hysteroscopy we do, whether we do a resection or an ablation. So that's why we can talk more about the ablation for that. So what was the question again in terms of the ablation?
Before that question, another question came in. What is a hysteroscopy?
A hysteroscopy is whereby, I'm going to go back to that. It's a procedure that can be done in the office or the hospital. The hysteroscopy entails basically putting a camera, a little scope inside the uterus, inside the cervix here. It goes to the vagina, and you look at it's a camera whereby you can look at the entire cavity of the uterus. It will tell you whether you have a fibroid that's in the lining, inner lining of the uterus. It will also tells you how many fibroids you have. It will tell you whether the fibroid is here blocking your tube. Okay, so in terms of the and then we use a hysteroscopy. If the fibroid is small, we can do the hysteroscopy in the office. Put a resectoscope. The resectoscope is like a little it's not like a spoon. It's a little, you can view it as a little as a little hook, and you can just like remove this with the little hook because it has a little heat, and you go poop and chop it off, and then use a forceps to remove the fibroid. Again, you can only do this in the office or at a surgery center when the fibroids are very small. If the fibroid is very big, okay, you have to go into the hospital to do it. When the fibroid is very small, depending on the patient, you can do this under you don't need general anesthesia, you may need regional anesthesia or pain meds, whereby they can do it in the office. But it has to be small, and you have to have preparation in case there's a complication. But if it's big, you cannot do this in the office. You have to go to the hospital. Now, the hysteroscopy resection, when you remove all the fibroids by shaving it off, okay? Now, the ablation is different. The ablation, you will not do an ablation for fibroids. You will do an ablation for patients who have what we call adenomyosis. And adenomyosis it's another common condition that a lot of women have, not only Black women, but white women as well. Now, the reason the ablation is different than resection, because when you do the ablation, it's done because you're having heavy bleeding. And the heavy bleeding is mainly due to a problem with the myometrium and the endometrium, the inner lining here, and some glands that cause you to bleed a lot. When you have the glands that's secreting, that's like contracting the glands, you're bleeding a lot. By doing the ablation, what you do with the ablation, you put a little balloon here, okay, in the uterus, in the uterine canal, like this area here. The balloon has, and you can use different types of balloon. There are some balloon that's filled with hot water. When you put it here, right here, for example, right, what it does is that it sort of like boiled or burn the inner lining of the uterus. And then when that happens, by having the burn can be due to hot water. It could be a mesh that has heat in terms of electricity. And I mean, there are various types of balloon you can use, or various type of device that you can put inside the uterus, basically to burn this off. And when you burn this off, and it'll burn also this layer here, what happens is that you form scar tissue. As a result, your bleeding will decrease by 50%. Again, ablation is not for fibroids, it's more for adenomyosis, which is a problem whereby you have excessive glands in the muscle of the uterus, right here that cause you to bleed.
So, thank you, Dr. Bercy. So should a woman worry about their lining if they have an ablation?
Oh, absolutely. We only do ablation for patients who are done with having children.
Yeah. So that's not an issue. And this particular person said that it actually stopped their cycle. I know you said it may reduce it.
Absolutely, yeah. It will decrease. Well, that's the beauty about ablation. Ablation, for example, when you're done having children, because we do not do this procedure in women who haven't had any children or who desires more children. It's all patient that said, oh, I who doesn't want a hysterectomy, we or another procedure, we offer them all the option, and usually the ablation is one of the primary procedures we offer. There are other primary procedures as well that you can have that we offer, but ablation is definitely very effective. For example, when you have, after you've done your period, you have adenomyosis, not fibroids, and you're bleeding a lot, ablation works very well. It will decrease your bleeding by 50%. And in some patients, maybe 20 to 25%, they'll have no period at all, and they love it.
Thank you.
So,
So let me step in and just do a time check. We are at, or just a little bit over the hour, and we really want to encourage people to stay if you can, because this is incredibly important and it's very interesting. So if you can stay, please do. And we'll let Dr. Bercy continue with her presentation because there are questions that are still coming in.
Yes.
I will now, let's just briefly, I will talk about therapies and treatment. So the choice of therapy or treatment one decide depends on many factors, such as age, right? The younger the patients, the least we're going to do, we're all going to offer them medical therapy. In that way, they preserve their fertility and not have any impact on the uterus at all. So that's important. The size of the uterus, if it's small, you know, that's different than when it's 20 weeks or you know, it's, you can feel it yourself. Some patients coming like, oh, I feel my fibroids. I think this one has growth, and they already know that. I'm like, okay, you know. And also too, if they have any medical problems, do they have anemia? Do they want more children? Do they have their diabetes, high blood pressure, obesity? And also there's, believe it or not, there are social factors such as housing, work, insurance, and where they live. So I will talk to you more about the social factor. In terms of housing, right? If the patient want to have surgery, they're like, oh, I have surgery, I need to have surgery. I said, great, you need to have surgery. And this came from an experience that I had with one of my patients. So, you know, I was young, you know, my first year in practice, and I worked her up really well and stuff like that. We did the surgery, and lo and behold, and I felt bad because she was living by herself and I could not send her home. So now I had to find housing for her, and finding housing proved to be more difficult than the whole surgery. That was easy, but finding housing to make sure that she had a safe place to go, she wasn't by herself in case something happened, was extremely difficult. So my lesson learned is that make sure when you're having surgery, it's great that if you have family, that's wonderful. But for those women who are single, living by themselves, that must be arranged either through a friend or, you know, have a friend or sister or cousin or whatever that you can stay with somebody for the first 3 days at least. That's when, you know, you tend to have a blood clot, you tend to, you know, if you bleed or something, but that's very important. And also to women who work, you know, to make sure that, hey, get all those things and worked up. In that way you get leave, in that way you can get paid. And also your insurance, certain physicians do not accept, you know, public insurance. So you make to be sure that that's in place. In that way, you know, you go to the hospital and make sure also too, you have the copay and all that. Now, in terms of zip code, we are very fortunate people that live in certain areas, that's not an issue, but patients who live in the rural areas, okay, that's a problem for them. Having been in Vermont, okay, some patients have to travel like 3 hours to get to a hospital, just like some places in rural Louisiana. So for them, they're suffering the most because they're like, okay, I have to travel 3 hours. okay, where am I going to stay if I have a problem? So they tend to suffer the most. So I really encourage my women that if you live in an area that's there, you still should seek care, because you should not be in pain and suffering for that long. But those, just to have those things in the back of your mind, and that's very important. So in terms of therapy, medically, we do things stepwise, just like surgically too. We do things stepwise. Just to quickly, because I know we're running out of time, there are hormonal therapy that we can use, especially when patients are bleeding. You know, you can use oral contraceptive pill to try to regulate their cycle, because sometimes they may have hormonal imbalance. And we use the birth control pill, low dose, and also too the progestin IUD. The Mirena works very well in controlling bleeding for patients who have small fibroids but who have more of a bleeding issue. We also have non-hormonal therapy. Tranexamic acid is a new medication that has come to the market. It's efficacious, and however, we do not use it with patient that has a history of blood clot, because there's increased risk of having blood clot, but it works very well. Now, in terms of the ablation, again, you know, that ablation, there's various types of ablation. That ablation I mentioned earlier was more hysteroscopic ablation, meaning that using the hysteroscope, whereby you can see, whereby you burn the lining of the uterus. The ablation that's being done by ultrasound and MRI, these are new modalities that we use, that it's been done, currently being done by the radiologists. And, you know, in the past 5 years or so, whereby they put the ultrasound, let me go back to my picture. What they do is this. So when they do the ultrasound or the MRI guided ablation, what they do is that they have the ultrasound machine on your belly, and they have a probe that goes directly into the fibroid, and using high energy frequency, it's sort of like burn off a blade, get rid of the burn off the fibroid, and as a result, the fibroid dies off. So, and also too, they use the same thing with MRI by using high energy, they're able to target the individual fibroids. Again, these are patients that whereby with MRI, you could see the fibroid clearly and delineated, and that way you don't hit other structures like the bladder or your bowel. So, and this is this sort of modality has proven very well for in the subset of women whereby the fibroid, they may have just one big fibroid, they can see it, boom, the probe goes in, the high energy frequency, and they use, they can see very well and then target that particular fibroid. Now, the other things that we can do if the fibroids are big enough, if the fibroids are big, we can do what we call removal, a myomectomy, whereby we just remove the fibroids, for example. And again, the myomectomy is reserved for patients who are young, who want to preserve their fertility, but their fibroids are big, they're having a lot of pain, a lot of bleeding, whereby we remove it. And ultimately, sometimes women will end up with a hysterectomy, whereby we remove the whole uterus with the fibroids. And again, those are for patients where they're done with their childbearing and they're having significant pain, and they have the most aggressive procedure. We try to, not to do hysterectomies first by trying these procedures first, and also too by having a shared decision making with the patient in terms of, you know, some patients I'll say, well, won't you just do a myomectomy? They're like, you know what, I'm done with bleeding. I'm done with my children. I don't want to bleed anymore. I don't want to have a period. Done, do it. So I said, okay, so we'll do a hysterectomy. You know, so it's clear in their mind. Most of my patients, they know what I'm going to do first, because they know I'm going to offer them the least invasive and then to the most aggressive, depending on their symptoms. Now, there's a time whereby we will do expectant management with my patient, meaning watchful waiting. It depends on their symptoms. For example, the patients who's pregnant, of course, we try to avoid surgery. The patient with postpartum, we try to avoid surgery until at least 3 months. Because for patients, you know, with pregnancy, we know that when you do surgery, depending what type of surgery you do, you can have pregnancy loss, preterm labor, and all that. For postpartum, the reason we avoid it at postpartum is because one, you know, that's the time they tend to be anemic because it's just blood loss tank having a baby. And number two, the first 2 weeks of you after having a baby is the time whereby most dangerous for women, because that's the time they have the highest risk of having a blood clot, the first 2 weeks. The last 6 weeks, they still have that increased risk of blood clots as well. And we don't want them to get a PE or any problems. So we avoid surgery in the postpartum period, and we tell them, let's just wait, if you need it. And most of the time they wait, they don't need it, and they do it a few years later. Now, if they're perimenopausal, meaning that they're close to menopause, we do watchful waiting too, because we know that once you reach menopause, your fibroids will decrease in size because we don't have the estrogen around, the hormone around that feeds the fibroid. So we do watchful waiting. What does watchful waiting mean? Watchful waiting is for patients who are having mild pain that can be controlled with Tylenol, and they're not bleeding a lot, they're not anemic, okay? And what I do for them is that I will do an ultrasound or an MRI in 3 months, and then 3 months later, I'll do another one. And then if they're stable, the fibroid is not growing, everything is good, then their symptoms is the same. And they say, well, no, I wanna wait. Then we'll do another MRI or ultrasound in 6 months, just to make sure everything is stable. But anytime they start having increased bleeding, I will do a biopsy of the lining of the uterus, just to make sure they don't have some kind of cancer inside the lining of the uterus. So there we do watchful waiting depending on symptoms. And also too, for patients who have high-risk medical problem, for example, if they're having chest pain, they've been evaluated by their cardiologist. And also patients who had a recent PE, had a blood clot in their legs, in their in their thighs, or also in their lungs. So we try to avoid having surgery on those patients because they are at risk for having another blood clot. We wait until they're stable and they're clotting blood clot medication. And also for patients who had a transplant, for example, we try to wait to make sure that they're out of the danger zone, which is the first, the first year or two. In that way, then we don't compromise their immune system. In that way, in that way they don't reject the transplant, whether it's a kidney transplant, because I had a lot of women that had kidney transplant for various autoimmune disorders. So therefore, we watch those women carefully. Okay, so this is a picture of you want a picture, just a picture of inside your uterus. So this is a picture of what a uterus looks like when you use a laparoscope. So this is the top of the uterus. This is the pearly hair or your ovaries, and this is your tube, your fallopian tube right here. And this is that big colon I was telling you about that goes that deep dive down. And interior on top here is your bladder, okay? So I have a quick YouTube video to show you in real time what it looks like. It's about 15 seconds. There you go. So this is again a picture of the top of the uterus, what it looks like, okay? And this is your ovaries right here and your tube. I will go let it play for you.
Entry is first made through the belly button to look inside.
So he's just inserting a trocar.
Being made from the left.
See, this is your uterus, so it looks like truly inside. He's gonna lift up the uterus.
The two ovaries, the two fallopian tubes.
This is true what you're inside. Every woman, no matter what color you are, that's what your inside looks like.
These ports help.
So in summary, fibroids are quite common tumors that women have, and it can cause significant amount of pain and discomfort. And the choice of therapy will depend on what you present with your age. So with that, I will answer any questions that you have.
Thank you so much, Dr. Bercy.
Dr. Bercy. Yes, thank you very much. And I don't want to spend a lot of time just being sort of in awe of just your knowledge and your ability to present such vast information. And ladies, as Dr. Bercy mentioned, so she did not address the endometriosis, and that was just a technical, and it's based on a technical issue. However, she can address questions related to endometriosis, but there are a few right now that we'd like to get through. I'll start with one, and then Cheryl will move to another. So I'm not sure whether or not the MS question was, if we could answer that now, or
Sure, I can answer the MS question. The question as is related to pulmonary fibrosis. Was
yes,
that it? Okay. So MS is a multi-system disease problem, and it can affect women, and also too, it seems that Black women are diagnosed later, and also too, they may have an increased risk. Now, MS is linked to being vitamin D deficient. Again, it's one of the autoimmune disorders that's been linked, and there's studies for that. That's why it's very important for women, for everybody to take vitamin D, and also to ask their primary care doctor to check their levels. So that's very, very important. The second thing, the reason that MS is linked to pulmonary fibrosis, MS is linked to, it's a multi-system disease, and there are multiple components to it. Once you diagnose with MS, you could have the progressive form. The progressive form is a rapid progressive form, meaning that those patients, they go down rapidly within a year or two, they usually pass away. The second one is the relapsing remitting form, whereby you have relapses, maybe every 3 to 6 months, maybe every year. Those patients tend to be a little more stable, and there's medication. There are new medication that has been proven to reduce the relapse rate by 50%, so which is great. In terms of pulmonary fibrosis, it can make your lungs, it can attack the cells in your lungs in that way, because it's an inflammatory disorder. Whenever you have something that's inflamed, okay, there tends to be can produce scar tissue, and pulmonary fibrosis is that. When you have the inflammation that results in the scarring, it causes you difficulties, first of all, to breathe, because then you're taking less amount of oxygen, and those patients tend to have severe difficulties, and to the point whereby it's very difficult, and it's one of those end stages whereby it progresses after you have MS, especially the severe form, within a couple of years. It can affect your kidneys, it can affect your ability to walk, and also can cause you weakness and numbness. And also too, it can affect your vestibular system, meaning that it can decrease your hearing, as well as other your skin issues. It can give you skin problems, skin lesions, and also to some patients. I had some patients. I'm in Boston, the area. There's a specific home that just take care of MS patients. So I had a lot of my patients that had MS. Some of them are able to walk and walk in the office, and some of them are bedridden to the point where they have both, incontinence, fecal incontinence. They cannot walk anymore, and but they're able to eat. So it progresses depending on the stage that you are. It can affect your vocal cords. so many aspects, and also too, it can affect your ability to speak, your ability to think. They call it the MS fog, for example, and it's very important for you, for specifically women. We need to take, I cannot stress this enough, your vitamin D3 every day, and make sure that you talk to your doctor, your nurse practitioner, get your vitamin D level to take. If anything, I would like you to do today is to go to the pharmacy, get your husband, your girlfriend, your boyfriend, or whoever it is, get that bottle.
So a lot of questions are coming in, and people also open up your mics if you want to. But a couple questions that came in during your talk. Do fibroids cause larger blood clots during your period?
Yes, it can.
Okay. And then another similar question. Well, maybe this isn't similar. Do you suggest getting any fertility tests or finding out egg count, AMH, before endosurgery?
That's a question of for endosurgery. Well, it depends what type of endosurgery that you're having, and also too, and having your egg count, and what do you plan to do with later. So I'm assuming that patient that doesn't have any children yet, so therefore they may want to get their eggs counted and see how it is, and possible do some egg retrieval prior to doing the surgery. So I'm assuming it's that. So I think that's a question they should ask their a surgeon, and also to make sure that why do they want to do that. If they want to do some egg preservation, that'll be a very good idea, because if a patient has stage 1 endometriosis, it's different than if a patient has stage 2 or stage 3 or stage 4. And so I would ask that what their fertility status is very important, and their desire for fertility.
Thank you.
I'm sorry if I might have had more confusion.
or not. And I would love that person who posted that question to respond and let us know if Dr. Bercy clarified that for you. And in the meantime, I have a question here that you had mentioned that fibroids are often benign. However, what is the connection between fibroids and uterine leiomyosarcoma?
Oh, sure.
Yeah.
Yes. It is extremely rare that women with fibroids will have underlying myosarcoma. Having said that, we always, when we're doing before surgery, if we're getting in a special MRI, sometimes if we see something that's not your typical fibroid, we'll work up the patient, and we will tell them to that we may send the fibroid to the pathology while we're there to look at it, to give us a frozen section, to be sure that there's no underlying cancer there. So if the fibroid by ultrasound and also to MRI look very suspicious, for example, if it looks suspicious on ultrasound, we'll do an MRI. If the MRI is suspicious for cancer, then we'll get a GYN oncology consultation, say, hey, I'm doing this fibroid surgery. However, the MRI is suspicious. Do you want to see the patient first, or do we want to do a surgical and operative consult while we're in the OR? Then you have that person available. If after sending it to the pathology lab, available in that way, then we can do one surgery at the time. There are cases whereby women, after doing surgery, for example, especially hysterectomy, it looked perfectly normal, but we send that specimen to the lab, to pathology, and it'll come back in rare cases as a leiomyosarcoma. Then we will send the patient to a GYN oncologist, whereby they get further therapy. But it is extremely rare.
It is rare. Thank you. And I think because that was the second part of the question, did the fibroid become cancerous in the case of uterine leiomyosarcoma?
Yes, there is a small chance that there is underlying leiomyosarcoma there.
Okay, thank you.
First call.
Thank you.
And another question from the group, is there any connection with the depot shot that stops your cycle when you get it to fibroids developing?
No, we usually use a depot in patients with fibroids in preparation for surgery, especially if they're bleeding a lot. We want to stop their period in that way to build up their blood count in preparation for surgery. But right now, though, there's a link between when you're on the depot for a long time, that it can cause you to have decreased bone loss. So we don't use keep patients on depot Povera for as long as we used to before, especially our teenagers.
Okay.
Thank you. Cheryl, did you want to, then there's
there's another one I can jump in. You can see all over the internet that there are all kinds of tonics, pearls that you insert, teas and herbal remedies. Is there any evidence that any of this is helpful?
Well, so far from what I've read, and then, let me make a disclaimer, please. That all this information can be found on UpToDate, okay? And UpToDate is a platform that I use to get all my medical information because they review the literature every 6 months and give you the latest studies, that's out there. And that way, I use that, and that way I can present the best evidence to my patients, to my colleagues. So I use UpToDate, and all that information, all the statistics that I've got it from UpToDate. And I've also shared some information with Janine and Charlene, send you a patient information that you can use, and also she has access to the website, so she can do any searches for you for the next 30 days.
That's perfect. And Dr. Bercy, there's a question. It says, I have adenomyosis, fibroids, and endometriosis, suspected endometriosis on her diaphragm. She's been going to and having VATS soon during her next lap. Lap. Have you seen patients with hernia, hiatal, and diaphragmatic lesions?
Well, I can tell you that you are very strong, because if you have fibroids, adenomyosis, and endometriosis up to your diaphragm, you've been suffering, you've been in pain for a while. I don't know if she will answer yes or no, because having, just go to endometriosis. If you have endometriosis on your bowel, and also let me go back to my slides.
Thank you. As Dr. Bercy is going to pull up some slides and probably to show us what she's going to share, please, if you're able to hold on, we're going to try to get as many of these questions in, and if so, it will be very helpful for us to know, just by your presence, that this is of interest to you and continues to be of interest, and that your questions are being answered. So we thank you.
All right. So if she has endometriosis on her diaphragm, okay, that means she's endometriosis all over. Not only is it on her small intestine, your diaphragm, briefly. So if this is your ovaries, you have small intestine all here, and the diaphragm is what basically covers here your intestine sac or drape over your intestine, just like your momentum is a drape here, your diaphragm is here. So endometriosis is basically glands that's glands that's all over. And sometimes the glands, they secrete blood. That's why some patients, will have some abnormal uterine bleeding. They may have heavy menses. But the thing about endometriosis is that when you have glands all the way up here, that means you probably have them all over. That means you're in significant amount of pain throughout the month, not only when you have your period, but all the time. And then when you have that happens, it can cause you to have diarrhea, difficulties eating, and sometimes too, the patient that have endometriosis they may have, it may migrate up to their lungs. I had a patient, for example, one patient I remember distinctly, every time she had her period, her lung will collapse. She'll have a collapse of part of the lung because the endometriosis had migrated all the way past the diaphragm into her lungs. And the only way that we found out like why this woman was going to the ER, you know, with breathing abnormalities every time she had a period. And lo and behold, she had a lung biopsy and it showed that eventually, and also to, at the time, it was years ago, you know, no one thought of it that it could be endometriosis all the way up there, all the way to her lungs, but we finally figured it out. And the way that her problem was resolved is that she had a medication called Lupron, and Lupron as a test just to be sure, stopped her period for 3 months and her lungs did not collapse.
Have you seen that since? How common is that?
So that is extremely rare.
Okay.
That's why none of us thought about it, because it's extremely rare. But eventually we did take care of her. And yeah, she did very well.
Thank you, Dr. Bercy. Another question is, when you say heavy menses or bleeding, is that on the first day, second day, or throughout? And what's classified as heavy, what you considered heavy bleeding?
Well, see, heavy, well, according to the classification, right? If you are bleeding, you should not be bleeding. Normal bleeding is considered 3 to 7 days, right? And based on studies, and also too, if you're changing your pad, most women will change their pad throughout the day, like 4 to 6 times, right? Right. So what's normal for you may not be normal for me, right? So therefore, we use those classifications, and also to the best way to find out if a woman is bleeding or not is to check their hematocrit to see if they're anemic, right? Because some women will tell me, well, I'm bleeding too much. And I said, well, how many pads you use per day? She said, I use 3 or I use 4. I said, well, that seems normal to me. She said, no, before I used to use 2 to 3. So that's a change for me. Okay. And there are some women that says, ever since I've had my period, I bleed for 5 to 7 days. Now I'm bleeding for 7 to 10 days. And I used to use 4 pads. Now I'm using 6 to 8. And I'm bleeding more than usual. And I'm passing clots. So that's different. But I always get a good history and check the blood count, because that gives me the true estimate. Because there are some women that will tell you, yes, I'm bleeding more. And I said, well, do you saturate the pad? They're like, no. So I get a history first and then double check with a hematocrit.
Thank you.
But if you change your pad every hour, you're saturating it. Or if you're changing your pad every 2 hours, you're saturating, you're passing blood clot, that is abnormal. That should not happen.
Okay, thank you. I just wanted to
tired.
Thank you. I wanted to reinforce the fact that that IAWH, that we, any advice that is given on the line is not to replace a consultation with your gynecologist or your, as she said, PCP, your primary care provider. However, this information is helpful because it's going to help you determine, it helps to inform your questions with your health professional. And Dr. Bercy has said that many times, that the conversations that you have with your PCP or gynecologist are very important, that you just be open and honest. And, sort of that, I love that question about, your heavy menses. Is it heavier now or before? And to use sort of that sort of gauge or judgment when you're speaking to your health professional to help them better understand what is the before and then the present, if that helps. There's a question. Do you suggest getting any fertility test or finding out? You mentioned egg count, but it says egg count AMH before endo surgery or
Right, that's the one. We did that one.
Did we do that one? Oh yeah, we did. I'm sorry. Okay. I'm trying to get all of them in. Cheryl, is there another one that I know there's several here that I'm moving down to.
While you read the question, this is an important message. Women, we should not be in pain. We were not born to be in pain. So therefore, if you're having pain, you must seek help to alleviate your pain. If you're tired, there might be a reason for it other than working as a mom, full-time mom, working as a full-time job, which can be sometimes tiring, and doing other things. So if you're tired, which is more than normal, and if you're in pain, no matter what the pain is, whether it's in your abdomen, whether it's when you have your menstrual cycle, it's very important to seek help. In that way, your pain is alleviated.
Thank you. I believe in response to one of your questions as to whether or not you answered, the woman said, I haven't had kids and have a lot of deep infiltrating endometriosis. So she feels a peace of mind getting an egg count done. So thank you. Could surgery affect your fertility as this person would like to have children? So could.
Sure. Do you have fibroids? If you have fibroids, depending on the type of surgery you're having, based on where your fibroids are located and how big they are, you could have infertility problem. So those patients, it's very important they do the least invasive so that their uterus is remain as is preserved or restored back to normality as much as possible. Because if you have multiple fibroids that are protrude in the cavity of the uterus, sometimes you have to do a resection, not an ablation, a resection, remove those fibroids so that you can achieve pregnancy. Now, having said that, sometimes when you have a resection, depending on how deep the resection was, because of how big the fibroid was, you may have some scarring in that particular area, which may impact your ability to get pregnant. And sometimes those patients, an egg count is good, egg retrieval is good, just in case if they're trying to get pregnant, they're not able to, then they have the eggs available with sperm, they can get a surrogate to carry the pregnancy for them because that child is biologically theirs. I mean, this is the logic, the way you think about it.
Yes. Yes. And the patient with endometriosis and fibroids and said that yes, she's had to. You said you are in a lot of pain, and she said yes, she's had to drop out of grad school and sharing just with other women and to get a full-time and quit her full-time job. So, exactly what you said. And she said thank you so much. She said it's been so hard with her lung collapsing every month. So
she has pulmonary endometriosis as well.
Yeah.
But there is help though for her. Have her physician should try the Lupron for 3 months because the Lupron, you can use Lupron in patients with endometriosis with IAWH therapy. And in some patients, the Lupron with IAWH therapy will help tremendously. In that way, they'll have no period. The majority of the patient will stop their period or diminish it significantly to the point whereby their pain decreases quite a bit.
And this is a question as well, and thank you for that response regarding endometriosis. Once you have laparoscopic,
it's hard to pronounce.
Exactly, a whatever. Okay, confirming the endometriosis, can it still come back? So, the laparoscopic procedure and confirming that it's endometriosis, can it still come back?
Well, a lot of times it's not the endometriosis. The endometriosis can come back, but a lot of times it's not it's because they didn't do a deep resection. So therefore, because using the laparoscope, you didn't have the definitive procedure for endometriosis is a hysterectomy. Okay. And unfortunately, sometimes the endometriosis is so deep in the tissue, even when you do a laparoscopy or a hysterectomy, you did not get all the endometriosis out, because sometimes, it's very difficult to get it out because it may be in structures that you don't want to touch. For example, there are some patients whereby if you look at this area, this area here, deep here, that's where the ureters are. Okay, and the ureter is the tube from your kidney to your bladder. And if the endometriosis is deep into the ureters, you want to avoid that, because if you nick the ureter, you may have problems with your kidneys, and sometimes it can cause, depending how, if you're trying to remove the endometriosis, you damage the ureters significantly, you may have issues with your kidney, to the point whereby the kidney, especially if the damage was not recognized early, you may damage the kidney so significantly whereby the kidneys need to be removed. So therefore, sometimes you may be able to just do hysterectomy and remove as much endometriosis as possible, knowing very well that you left some a little bit in there, because the risk of trying to remove that a little bit was not worth it. But then you tell the patients that, and that patient, will understand, hopefully, you were doing things in their best interest, but their pain should significantly reduce. But it's not too uncommon for patients to say, oh, my endometriosis come back. Yes, in rare cases, that's because there was some left, there are some glandular tissue that was left there, one, because of potential complications, or two, it's just not visible because it's so deep in, we didn't see it.
So, Dr. Bercy, I have two questions, and I know that we're running late on time. We're going to launch the evaluation, so everybody please stay put just for a few more minutes. A couple questions. Someone asked if it's okay for us to share your notes with attendees here, just so that they can have the notes, and is that okay with you?
Let me modify them a little bit, and then after that, I will send them to you. Is that okay?
Oh, that's great.
Absolutely.
And the second question, for fibroids, the UFE as a treatment, can fibroids come back after that treatment, or do additional ones grow?
Let me tell you about UFE. That's an excellent question, and I'm sorry we're out of time. I did not discuss UFE, but UFE is one of the it's invasive, but it's one of the lesser invasive treatment that exists for uterine fibroid. In fact, I used to do UFE as well early back in the early 2000s. It's a surgery that essentially was pioneer in Europe because of the current system that exists in Europe. So basically, the way it came into market or became a therapy is because in Europe, women have to wait for their surgery. So the radiologist, brilliant radiologist, said, hey, why don't I, since we know that the fibroids are estrogen dependent or response to estrogen, and also too, what if we decrease the blood flow to the uterus, right? By basically blocking the uterine artery, which is like located here and down here. So what they do is this, after doing a MRI, okay, to locate exactly where the fibroids are, as well as if they can access to the uterine artery, which is here. What they do is that they insert these pellets. We insert these pellets using one of the big vessels in the in the thigh, right? And we do it in radiology. It's basically like an angiogram, you know, basically an angiogram, almost like that. You use the catheter, you put it in the vessels of the big vessels of the thigh, you thread it up to the uterine artery, and you inject these pellets into the uterine artery, thereby decreasing blood flow by 50%. So if you decrease blood flow by 50%, the fibroid will start shrinking. And studies have shown that based on the research that was done, and the person that's considered, like, at least in the greater Boston area, his name is Kim Duck Soo. He's done 1,000 of these cases. And earlier on when I was doing more clinical work, I used to do these cases with him. And we've been shown that they reduce the size of fibroids as well as bleeding up to 40%. Okay. So in Europe, because the women, they did the procedure while women wait for their surgery, and they found out, oh my gosh, it decreased my bleeding by 40% and reduced the fibroid. I'm not having surgery anymore. So we brought the procedure to the United States. And when I did it with Kim Duck Soo, you know, he's a interventional radiologist, I had the same results among my patients. So we were doing it for patients as well. And it decreases their period. They went back, the surgery is done in radiology they didn't need anesthesia, they didn't need local anesthesia, and patients were able to go back to work within 3 to 4 days. Okay, so which was like fantastic. The only caveat is that patient will experience intense pain, and because as the fibroid you know, is shrinking, you know, they experience a lot of like cramping. They're like, oh my gosh, I'm having contractions. I said, you are having contractions, that's because the uterus is shrinking, but we can control that with pain medication. So we give the patient pain medication, and their cramping decrease, their bleeding initially might be a little bit heavier the first few times, but after that they did very well. They're able to go back to work very quickly, no general anesthesia. So that procedure now has become routine as well for fibroids. So it's a great procedure, and I'm sorry I didn't mention it. It was just due to the interest of time.
No, you have been thorough. Thank you. Thank you.
Thank you so much.
There's another and I know we're going to have to stop, but does tranexamic acid affect ovulation or fertility?
Tranexamic acid is a medication that we use. So far, we don't know. It does not affect your fertility, but the main complications we know for tranexamic acid is the risk of thromboembolism. So we have to be very careful. We use it in patients that have a family history of blood clots, for example. We tell them that there is that risk, and we don't want you to put you at increased risk. And we do have other medication that we can use for the fibroids first. So let's use that as our last resort in case you cannot have anything else.
Thank you.
Thank you.
This has been tremendous.
Thank you so much, Dr. Bercy. This has been phenomenal. Really, you've covered so much territory, and we did go over time, but it was very much worth it. And we really want to thank you for your time this morning. Because
we thank the ladies for
anywhere, but we thank you for coming and sharing your time with us this morning.
You're quite welcome. I love to take, hopefully I didn't, you know, overdid it with my slides, but
No.
So thank you. It was an honor and privilege for me. So whenever, if, you know, I'll work with you to do the endometriosis session as well.
You are phenomenal, and your the information as well as the diagrams and the pictures are all enhancing. And I think for most women, including myself, you know there's things you don't, but it's not until you take a look at what's happening inside of your body that you have a better understanding. So, and there are many kudos also in our chat, and I cannot go through all of them, just giving you kudos, Dr. Bercy. So thank you. And Cheryl?
Yeah, we do want to launch our evaluation, but at this time it's not launching. again. This is the second week.
Okay, well then what we'll do, we'll include the evaluation when we send
A follow-up to
a
everyone.
follow-up to everyone on this call and everyone who's registered. We will include the evaluation. We hope you keep in mind, you know, sort of the flow of this call, the information and resources that have been provided to you, and information particularly, and several notes that Dr. Bercy made about vitamin D3, having discussions with your physicians, your gynecologist, PCP. I'm sorry, Cheryl.
No, I didn't say anything.
Oh, I thought you said something. And again, if you're in pain, Dr. Bercy reinforced that if you're in pain, we should not be in pain. Have those conversations and honest conversations. Dr. Bercy, any parting thoughts that you have that before we sign off?
Well, again, it was really seeing all your lovely faces and being in the community among women. Women's, you know, health is my passion, and getting to be a better advocate for my patients, and also to, you know, it's very, very important. And as I said before, you know, you should not be in pain. You were not born to be in pain. Seek help. I know sometimes it's difficult, especially if you're working, you know, have many, many jobs and wear many hats. So, you know, keep on going, and, you know, try to do your best every day. And, you know, again, do not be in pain. There's treatment out there and you can get help. Thank you.
Thank you, Dr. Bercy. You've been so phenomenal. There's been questions whether or not you offer telehealth services. So we'll learn more about how anyone, if they're able to get in touch with you, and how your services are, additional services are provided. But I'll tell you, you've provided us with a great service. So
Thank you so much.
It was my pleasure, and God bless you all.
God bless you. Thank you. And every woman on
Everyone have a wonderful weekend.
Yes.
Thank you so much for attending.
Thank you. We'll share more information later. Thank you.
Thank you. I'm glad my boys didn't come and ask me a question, because every time on a webinar, I have a question. Everybody seems to have a question. Yeah, I'm glad we did it early in that way. They're just about to get up.
Thank you.
Have a question for me. So
Thank
have
you.
a great day.
You too. Thank you.
Bye-bye.
And we'll reconnect. Bye. Thank you. Thank you, everyone.
Janine, you want to stay on?
Yeah.